Marks, clinical lead of Integrate Families National Center of Child Trauma and Dissociation in England, national and international training on the topic of assessment and treatment of child trauma and dissociation.
Okay, thank you very much, Rachel, for being here. I've just had a shock. I hear I only have half an hour instead of 45 minutes, and I've already cut it down from a day. So I'm going to go in fast forward. I just want to ask, I know there's a video being taken, but I just want to ask that you don't take any photos because this is clinical information and no other video recordings, please. Now, thinking about dissociation in children, and I'm going to talk to you about the assessment specifically, it's very much, to me, like a tortoise. And I'm thinking about, and I'm explaining very often to the children, you know, this is like a tortoise right now. I really, really would like to know what is happening inside you. And I can see only the shell. I don't see anything else. And if you would like me to help you, we need to work very, very hard to try and find the little leg in this tortoise and to find the head in the tortoise. Because what is happening very often is if you work with dissociative children, and we've heard that yesterday again and again, a child might be referred to you that is sexually abused, and you really need to get information. And what do you get? You get nothing. The child cannot remember, the child cannot give you anything. These children are masters in deflection. Look at the spider. Oh, look at that spider. Can we do something about the spider? I'm just quickly going to the toilet. Can I have some water? Oh, I'm so hungry. Oh, this is boring. That's all very, very typical. And so what happens is that I often found in doing supervision, which I do internationally, is that therapists are saying to me, do you know what? I'm seeing this child, and this child is really, really difficult to work with. Actually, sometimes, you know, this sounds horrible, but I wish the child would not come for the sessions. It's really, really hard. Or they will report, I'm really confused. This child is so confusing. Well, both of those might indicate that you're actually working with a child that is highly dissociative. So, what I've learned about tortoises, and I'm originally from South Africa, is that you have to work very, very hard and very long for a tortoise to actually stick its head out. If it is not a tame tortoise. I mean, you've got to tickle it here, you know, very gently, if you can get a bit of a leg. And you've got to be very, very patient. And that is exactly what it is to work with children that are dissociative. I think there is no shortcut. There is no quick way that you will just be able to get to the dissociation. But there are some ways that you can get to it when you assess children. Now, the first thing that we need to do is we need to change our assumptions. And I think very often people have the assumption that children are mini adults. So I trained in how to work with adults, so I'm going to transfer my skills and I'm going to start to work with the children, and we're going to talk and have a discussion. I very strongly disagree with that. The brain of children work very, very different. Children developmentally are very, very different than adults. The language of children are very, very different. Because, you know, I think that you need to be able to learn the language of children before you can work with it. So presently I speak Afrikaans, I speak English, I speak a little bit of German, and I speak child language. And that is very, very helpful because my child language, I can understand children's language, I can speak children's language, and that is actually very important that you learn that. So, the next thing that we need to know is that children remember memories very different from adults. I have worked with adults at some point, but I have stopped because I'm inundated with children. And it's easier for adults to verbalize information than with children. Children are are talking through their behaviors, they are talking through their bodies. Not that adults don't, but children do it much more than adults. And so the other thing that we see is that there is an assumption in the world that children don't remember. So actually, you know, we can, like I see in England, we can do sometimes a little operation without anesthetics with children. You know, they don't really feel. You know, we save money and they don't feel. So that's not a problem. Bad things happen to children. Like what I often see is that the child has been abused, so the child is moved. Let's say the perpetrator is losing the child, at least, because in England very seldom they go to jail. But the child doesn't really need help because children forget. You know, the child was very young when it happened, so the child will forget. That is a general assumption, which we know is not true. Children do remember, and they do have very, very clear memories. And then also, I think you have to be very switched on to see what children's bodies are doing and what they are experiencing sensory. So what happens is when I train therapists to work with dissociative children, they often come back after we have done the assessment training, which, as I say, is a full day. And after a couple of weeks, they say, "Oh, I have missed so many of these children. I don't know what happened, but all around me, I suddenly see dissociation in children." And these therapists are all working with traumatized children, and they are doing a good job, but they've never seen and never noticed the dissociation. And then I think children are fascinating. I have seen that we did a little bit of a study. Unfortunately, I'm sitting on a gold mine of information and I don't have a researcher, and I'm a clinician. I'm more on the carpet or busy with training than anything else. But one of my colleagues looked at some of the work that we do. And we actually found that 96% children are referred to us because of behaviors. And so what has happened, these children had between 2 and 4 therapies already before, and there's always been a reduction in the behavior, and then the therapy stopped, and then the behavior escalated again. So what is very interesting is I actually see behavior as a part of the language of children. I don't see it as something that's supposed to stop. And I also say to the parents, you know, I'm not going to stop this behavior. It will just have to continue, you know, until we have resolved the issues for the child. So I have termed this trauma-based behaviors. Now, at one given moment, we have about between 100 and 120 dissociative children that we treat, which is quite a bit. And so how does it look when you see a dissociative child? Well, actually, there's no difference. You have many children that are coming in, that are friendly, that greet us, that are appropriate, they are cooperative, they are, you know, there's, sometimes I just sit there and I think, I wonder why this child is here. Because the other thing that I need to add is that we do all our assessments blind. We do not have any information about the child before we assess the child. And the reason for this is that I have read many, many reports in my life, and all that the reports of the professionals actually is saying is what the parents and the teachers already say, even if they've seen the child. So we are going in blind. We don't know why the child is referred. And so we have to be very, very switched on to get any information. So I would be sitting and thinking, I can't think why, you know, why would this child be here? I mean, this child is just so, everything is fine, there's just no problem. Well, that's very often the problem. And then somewhere during the assessment, we only do one assessment, that's between 2 and 3 hours, somewhere in the assessment, suddenly I start to see something different. or the child will say something. Now, what is important, I think, and I presume that many people that's sitting here might be thinking, wow, Renee is going to give us this magic key how to assess children. And actually, I think there is no magic key apart from you having to change how you see children and what you hear when they talk. Ono said very early on, see and hear. And I thought, that's interesting, because that's exactly what it is. It's what do you see? If you see behavior, that's very sad. You've got to look beyond the behavior. If you just see or hear something that the child is saying, and you do not ask the correct questions because you assume you understand what the child is saying, you're going to miss the dissociation. So, in order to assess dissociation in children, we need to know a couple of things. The first thing we need to know is dissociation is a common phenomenon in children who suffered complex trauma. So children who suffered one single trauma can already become dissociative, but where we have children where there's been repetitive different types of trauma or one single trauma that repeated, there is a very high likelihood that there might be dissociation. And you can see there's a reference that multiple traumas is associated with the highest level of dissociation. It is not that the child is not showing the dissociation, it is that we are not trained or not switched on to actually see it. The second thing is we need to accept that there is something like a split. I don't like the word, but I specifically put it in here because I think that is the word that many people actually understand. And so I refer to Ono, and I'm very glad Ono is here. First time that Ono is here while I'm presenting, but I very seldom do a presentation without referring to him. And he is saying that the ANP uses the EPs as a mental protection, and that is like the shell of the tortoise. In that these EPs contain emotions, thoughts, fantasies, wishes, needs, and sensations that the ANP believes to be unbearable and unacceptable. Now you see, where I work with the children or even with the adults, that concept is a very, very alien and complex concept. I mean, even in England, in the general practice where they are, where we work with mental health in children, dissociation does not exist yet. I guess that's why I'm so busy. So, what I do, I explain to them the ANP and the EP in a very elementary level. I will say, well, this is you, and you are this very, very beautiful rabbit. And because I love rabbits, if they say, well, why do you choose? I love rabbits. And so you are 12-year-old and you are doing all the 12-year-old things that you're supposed to do. Now, I need to let you know, most of the time, it's the 12-year-old that will attend the therapy session or the assessment session. And that's a bit of a problem, because if the ANP is attending the session, you might never see the dissociation unless you ask the right questions. The other problem is you give any forms to the ANP to complete, there is a high likelihood that the forms will say there is no dissociation. Okay, so that's a bit of a tricky thing. And then, of course, what happens is sometimes you go away. And when you go away, what happens is that we will get, let me just see, where is the right one? Here. Okay, so let's grab this one here. There we go. And out comes this one. Now, many children actually are coming because they are very, very aggressive. We work with very violent children. And so the aggressor is coming out and very, very angry and, for instance, hit the parents and then goes away. So what happens then? The parents will say, 12-year-old ANP is coming out, and the parents will say, why did you hit me? What? I didn't. I promise, I didn't do that. Honestly, I would never, ever hit you. Yes, you did. No, it's not me. Yes, you did. No, it's not me. Look at this blue mark on my arm. No, it is not me. Can you see? And then it goes again. And then we have this very young, infantile little part coming out. That is like 3 years old. Some of you were here yesterday when we saw the video and we saw the adult actually switching. It's exactly the same with children. But very often we call that behavior with the children. In England, it's called silly behavior. If the child regresses, the child is having silly behavior. If the child is hitting and fighting people, then the child is aggressive and the child needs some punishment or exclusion from school. You see, that is how we usually deal with that. So I think that gives you some idea what we need to understand. We are actually working very often with hidden parts of the self, and that is a very big problem. So let's see if I can quickly show you some information here. Oh, the other thing that we also need to know is that the children's presentation of dissociation is not similar to that of adults. You know, it is different. I think we also see children who were suffering severely from pre-birth and severely after birth. And those children very often do not have an A&P. There is no functional part. They cannot go to school. They are totally dysfunctional. So how do they look when they arrive? Well, it would be something like the parents will come in and the therapist will meet the parents and go like, and where is Sarah? And they will say, oh, you know, Sarah is in the car over there. Sarah refuses to come out. Now, usually what happens if the child remains in the car, the therapist would not assess a child. Well, it doesn't work that way where I work, because we know already if a child of 15 would visit anywhere, they would usually arrive. If somebody is in the car, that is usually perhaps something else. That might be dissociation. So the therapist would go and do the assessment in the car. And not long, suddenly the child would be, of course, very quickly regress, and then at the end said to the therapist, you really understand me, you really get me, because I have all these different parts. Or, like one of the children came in, a young child of 13, and when the therapist met the person at the door and put out his hand to shake the child's hand, or he wanted to high-five him, that's right, wanted to high-five him, the young child stand there, the young man, and said, well, all I want to do is to spit in your face. Okay, now, usually what will happen, that would be the end of the assessment in many places in England. And the therapist said, so you can spit well. Brilliant, we can have a spitting competition today. And immediately the child came in and a full assessment could be done. So you have to be very creative very often to see the children if they do not have a functional A&P. So, when we look at the assessment, I'm just going to leave you with a couple of tips, and tomorrow I will continue. The important thing is, what do I see during the assessment? What do I see? You have to be switched on. If I am ill, I do not do assessments. I've got to be well rested and I have got to be functional to do an assessment. What do I see? We usually do, as I say, a blind assessment, which is psychological assessment, and then we observe. So, 11-year-old Shauna, is coming in. And while I'm explaining about what we're going to do, the mother is there, and usually I get the parents in and the child just to explain what I'm going to do, and then the parents leave and I assess the child. I see that Shauna is starting to stare. Okay, now, most children stare. What do we usually do if they stare? Oh, well, we just ignore it because they will stop staring and then we continue. And sometimes they can look right through us. You know, it's like they look right through you. And so I said, Shauna, and Shauna listened, and then I continued. But very quickly, Shauna stared. And then I stopped talking, and I just waited. She was just staring, and I was like, oh, she's lost me. Waited a couple of minutes, and then suddenly she did this. She was like, what did you say? And I said, where have you just been? And she just laughed, was nowhere. And I said, have you heard what I said? And she said, no. I said, while you were away? She said, no. I said, oh, okay. Gave her a piece of paper and say, I would love you to draw the place where you've just been. And she said, I can't draw. I said, don't worry, you know. The best thing that I can draw is a stick figure. So this is not, you know, you don't need to draw in here. I just want to know where you've been. Can you draw that? And Shauna drew this, to bed. Now that's very interesting. We can discuss that bed, but you can see it looked very utterly deprived. There's a toy on the bed, apparently. And then, very clearly, she is now already staring and disconnecting while she's here with me. She also said to me, I said, where do you do that? She said, oh, in the class. In the English class I do it, and I do it in the science class. Now, what is interesting, I do a lot of school observations. And if you look at the children, you can see how they function, how they disconnect, how they lose information for 5 minutes, 10 minutes, 3 minutes. Then they continue. And over time, they lose so much that they cannot really function at school very well. And of course, it's also happening at home. Now, what am I actually seeing here? The first thing is I see clear derealization, where she is going away into a different world that's much more comfortable than the world that she's in right now. Now, I need to tell you, if you ever work with a child or you try to assess a child who is actually in using derealization, you are wasting your time. You know, because they're there, not there, there, not there, there, not there. So what I did, I was like, okay, right. Well, you know, I see that you go away a lot while I'm talking. So you can choose. You can either fiddle with this. Actually, I don't have these little toys. I've got loads. You can choose. You can fiddle with this. Here's another one you can fiddle with, or you can have a lolly that you can suck, or I can give you chewing gum that you can chew. I need you to stay here with me while we are doing this assessment. Can you see? Because that's really, really important. And sometimes you've got to vary this, otherwise you're going to lose the child during the assessment. The other thing that I see is already possible amnesia. She's missed the information that when I talked, and I need to look at possible amnesia. And of course, with all my experience, I would have already wondered whether the little toy on the bed isn't a part of the self. Okay, so also, what do I hear during the assessment? So, I assess 8-year-old Jimmy. Now, 8-year-old Jimmy is very talkative, so he's talking about the school. He is telling me about the teachers that he likes, the things that he doesn't like at school, etc. He's also talking about his friend. He keeps talking about his friend, and he's got a friend that helps him. So, what would you hear? You know, the friend is talking to him, the friend is helping him, and it's all mixed in with the information about school and football and all the fun things that they do. But now I am hearing something. I hear about a friend, and I wonder about the friend. So, I asked him, what is the name of this friend? He said, Bob. I'm sorry, Bob, but, you know, we've got a lot of Bobs there where I work. I don't know why, but any case. So it's interesting, we've got a number of children with dissociative states with the name of Bob. Okay, and he told me that Bob The Bob is his name, and Bob is his best friend. Okay, again, what do you hear? Just a child with a best friend, 8-year-old, that's very normal, isn't it? But now I'm going to ask a very important question, because I heard about a friend, and the friend is obviously very important. And I say, where do you usually see Bob? And he says, I don't see him. Oh, you don't see him? Okay, so can you tell me where is he? Oh, he's in my head, he talks to me. Can you see? So you have to hear very carefully. You've got to pick up information. You've got to see what the children are doing. And I asked him, I always ask the children then to draw. I asked him whether he could draw Bob. Well, there's Bob. And if you look carefully, you can see Bob has got a gun here. And so found out that part of Bob's task is actually protection. And specifically at school. So we talked about school, and that immediately triggered some threatening feelings. And so we started to talk more about Bob. And actually Bob is the one that's helping him. Of course, history of violence at school, etc. So also, here we have an imaginary friend. We also have evidence here of the child disclosing that I am hearing voices. Now, also you've got to see what happens during the assessment. And I think I'm going to skip this one for tomorrow. I'll do that. What I will just do, I will just do this. I will say to you what is really important. We also then, after we've done the assessment and after we have collated all the dissociative little pieces that the children have given us, we then have an interview with the parents, and we get information from the parents about what the children are saying. We also have direct questions that we ask the children, but very important is what parents report. Because parents would report, for example, in the case of the one child, they would report that the child is doing a lot of very unusual sexualized activities and has no memory. In the second case, there's a child that is very aggressive, hitting and hurting people and cannot remember. And of course, that is giving us very important information. We also ask the parents then to complete a form, which I will discuss tomorrow, that can also give us information on the dissociation. We also make contact with the schools. The schools are very helpful to let us know information that's important. We often give them a form to complete as well. And in all cases, we do school observations. And in the school, you will find really, really fascinating information. So when you assess a child for dissociation, it is about what you see, what you hear, the answers to the direct questions that you've asked the child. It's the forms that the child completed. It's the information from the parents. It's all the behaviors that we get that actually indicates dissociation from home, from school, and together you build a puzzle so that you on long term know what you are actually working with. So, I think I'm going to end here. What I just want to say is that whatever you do, it's very important not to dissociate the dissociation, but to make sure that you are switched on and that you're aware of what children are doing around you. Thank you very much.